Welcome. Mode evaluation of a strabismus patient consists of two sets of examinations. In one set of examination, we assess ocular alignment, that is the relative position of the two eyes in various positions of gaze, and in the other set of examinations, we assess ocular movements towards various positions of gaze. In this session, we will be discussing examination of ocular alignment, and in the next session, we will be discussing assessment of ocular movements. And we must be able to distinguish between these two sets of tests. For a patient presenting with symptoms of strabismus or abnormal head position, we inquire about the age at onset of symptoms, if there is any history of trauma or illness at onset, whether the strabismus is constant or intermittent, and if intermittent, whether it is present only during inattention or fatigue, whether the strabismus is unilateral in which only one eye deviates, or is alternating in which the deviation alternates between the two eyes, and whether the strabismus is present only in or is increased in certain gaze positions, at near fixation, distance fixation, or both, and whether there is any associated diplopia. If the patient complains of diplopia, we have to inquire whether the diplopia persists even after closure of one eye, and this is called monocular diplopia. The diplopia in a strabismic patient is binocular diplopia because the patient perceives diplopia only when both eyes are open, and when one of the eyes is closed, the diplopia disappears. Monocular diplopia occurs with media abnormalities such as corneal irregularities, cataract, uncorrected refractive errors, and retinal distortion such as may happen with epiretinal membranes. It is also very important to ask a patient perceiving diplopia whether the separation of the two images is horizontal, vertical, or oblique, because that will tell us a lot about the muscles which may be involved in a strabismic binocular diplopia. We should also inquire about the variability of the separation with time, gaze positions, and distance of fixation, and whether one or both the images are blurred or distorted, and whether the diplopia disappears with blinking. We also inquire about previous ocular diseases and treatments such as occlusion therapy, refractive correction, and eye muscle surgeries. Before we start discussing about the individual tests of ocular alignment, we have to clarify certain terms and concepts. Heterophoria is a latent squint which can be controlled by fusion, and heterotropia is a manifest squint, manifest because it cannot be controlled by fusion. The abnormal ocular alignments which we may come across in strabismic patients are as follows: exotropia and exophoria, referring to outward deviation. This diagram showing a patient with exotropia, esotropia and esophoria referring to inward deviation. This diagram showing esotropia, hypertropia and hyperphoria referring to upward deviation. This diagram showing hypertropia, hypotropia and hypophoria referring to downward deviation. This diagram showing a patient with hypotropia and torsional deviation as shown in this diagram. The abnormal ocular alignment in a strabismic patient can also be any combination of these deviations. The examiner must distinguish between tests which may make binocular viewing of everyday life, thus allowing fusion between the two eyes, and tests which disrupt fusion. Tests which do not disrupt fusion allows measurement of heterotropia, but tests which disrupt fusion gives the maximal deviation only, that is heterotropia plus heterophoria, and cannot distinguish between the two. The examiner must also be able to distinguish between tests which control accommodation and tests which do not. Accommodation contributes to deviation because of its association with convergence in the near triad. Tests which control accommodation stabilize the deviation between the two eyes and thus allows accurate measurement of the deviation. So before performing any of the tests for ocular alignment, we must know whether the test allows fusion or disrupts fusion, and whether the test controls accommodation or not. Ocular positions in which ocular alignment should be examined include, for distance fixation, the 9 diagnostic positions of gaze, right head tilt and left head tilt. When the patient tilts head to the right or the left, The patient also attempts to reorient the eyes by a torsional movement to have an erect perception of a target located straight ahead in the visual space. So, dysfunctions of muscle which cyclorotate the globe can be assessed in the right head tilt and the left head tilt position. Ocular alignment should also be examined at near fixation in primary position as shown in this diagram. In pseudostrabismus, there is an appearance of deviation between the two eyes without any actual deviation being present, and pseudostrabismus patients show normal results in ocular alignment tests. Conditions causing pseudostrabismus include epicanthal fold simulating esotropia, that is inward deviation of the eyes, telecanthus or hypertelorism simulating exotropia or outward deviation of the eyes, vertical displacement between the orbits simulating vertical deviation, lower lid retraction simulating hypertropia or upward deviation of the eye, and a patient with large angle kappa also appear to have strabismus. We will be discussing angle kappa when we discuss corneal light reflex tests. We can note here that patients with hypotropia or downward deviation of the eyes usually have an associated pseudotosis or false drooping of the upper eyelid in the deviated eye. Tests for ocular alignment can be grouped into cover tests and corneal light reflex tests, which are objective tests and subjective tests for ocular alignment. Cover tests can detect as well as measure horizontal and vertical deviations, but cover tests cannot measure torsional deviations. For cover tests to reveal the status of ocular alignment in a patient, the patient must have foveal fixation in both the eyes. In a patient with eccentric fixation, cover test is liable to give erroneous results. Ocular movements must be present in both the eyes, which should be normal or at least partial, so cover tests are not possible when there is complete loss of movement of either one eye or both the eyes, as seen with total paresis or total restriction. And the patient must have an ability to maintain fixation on an accommodative target. So cover test will not be possible in a very young patient who is not able to fixate on the target, and is also not possible when one or both the eyes have very poor vision. So these three prerequisites of cover tests are important to remember. The term accommodative target is very important in strabismology. As the subject focuses on the accommodative target controls accommodation and thus stabilizes the deviation between the two eyes for accurate measurements of the deviation. An accommodative target usually resembles an object or a toy, as shown here in this diagram. Light source is not an accommodative target, and this is very important to remember. This is because the subject cannot focus on a light source, and since the subject is not able to focus on a light source, tests which employ a light source cannot control accommodation, and there will be variability and inaccuracy in the measurement of deviations. The target is usually of 612 size, and the patient is asked to describe the target before the test is performed to ensure that the subject has focused on the target and so accommodation is controlled. Cover-uncover test detects heterotropias and can differentiate between heterotropias and heterophorias because it does not disrupt fusion, which alternate cover test does. Cover-uncover test actually has two components. In the cover test, we observe movement of the second uncovered eye when the first eye is covered. And in the uncovered test, we observe movement of the first covered eye when that covered eye is uncovered. In the cover-uncover test, patient maintains fixation on an accommodative target. One eye is covered and the cover is kept in that position for several seconds while movement of the uncovered eye is noted. The cover is then removed and movement of the first eye, which was initially covered, is then noted. So this part is the cover test and this part is the uncover test, and we note here that in cover tests we note movement of the eyes and not their positions. The test is then repeated with the other eye. When one eye is covered, if the second eye moves, heterotropia exists. If the second eye moves nasally, then the deviation is exotropia. If the second eye moves temporally, then the deviation is esotropia. If the second eye moves superiorly, then the deviation is hypotropia, and if the second eye moves inferiorly, then the deviation is hypertropia. This diagram represents the situation in a patient with left eye exotropia. So when the right eye is covered, the left eye moves nasally, denoting exotropia. Actually, both the eyes move in the same direction according to Hering's law, but the movement of this eye is not seen because of the cover. When the cover is removed, there are three possibilities. If the first eye remains deviated, then it is an alternating heterotropia because the deviation has alternated from the left eye to the right eye. The second possibility is that when the cover is removed from the first eye, the second eye again goes back to its deviated position. Then it is a constant heterotropia because the deviation has persisted in the same eye after the performance of the cover-uncover test. The third possibility is that the first eye moves to take up fixation, but the second eye does not move. Then it is called a heterophoria, and the pre-existent tropia is then labeled as intermittent tropia. Heterophorias can also occur without a coexistent heterotropia, in which situation during the cover test we will not find any movement of the second uncovered eye, and during the uncovered test we will find movement of the initially covered eye, but we won't find any movement of the uncovered eye. We will watch the movements of the covered-uncovered test once more. So with a patient with left eye exotropia, when the right eye is covered, the left eye moves nasally, and when the cover is removed, the right eye may remain deviated in alternating heterotropia, or the left eye may become deviated in constant heterotropia, or the left eye does not move and the right eye moves to regain fixation when it is called a heterophoria. Among the cover tests, alternate cover test interrupts binocular fusion maximally, and it thus measures total deviation, that is heterotropia plus heterophoria, and is not able to distinguish between them. Patient fixates on a distant accommodative target. One eye is covered for a few seconds, then the cover is moved quickly to the other eye where it stays for a few seconds before returning back to the first eye. What is important to note is that the cover stays over an eye for a few seconds and the cover quickly moves from one eye to the other. One common mistake in performing the alternate cover test is to keep the cover over an eye for a moment only before going back to the other eye. So when we perform alternate cover testing on the same patient with left eye exotropia, on covering the right eye, the left eye moves nasally, and on covering the left eye, the right eye moves nasally. So both the eyes move nasally, and this suggests that the patient has an exodeviation, and this exodeviation is sum of exophoria and exotropia. We watch the movements once more. When we cover the right eye, the left eye moves nasally, and when we cover the left eye, the right eye moves nasally. Prisms are used to measure ocular deviations. In prism and alternate cover testing, the prism is held over one eye while alternate cover test is done, and the power of the prism is adjusted till there is no movement of the eyes. And at this point, the power of the prism denotes the magnitude of ocular deviation. Some patients, instead of showing no movement as endpoint, show change in direction of movement, that is, movement in one direction with one prism strength and in the other direction with the next higher prism strength, and the midpoint of these two prism strengths is taken as the measurement of the deviation between the two eyes. And an estimation of ocular deviation with an error margin of 2 prism diopters is considered to be acceptable. So when we perform the prism and alternate cover test on the same patient with left eye exotropia, we position the prism in front of one of the eyes. In this diagram, it has been shown that the prism has been positioned over the deviated left eye. What is important to note is that the apex of the prism is towards the deviation. So in case of exotropia, the prism is positioned over the left eye with the apex pointing towards the left. And in this patient, if the prism had been positioned over the right eye, the apex of the prism would have been directed towards the right. Now we perform the alternate cover test, and when we cover the right eye, we find that the left eye moves, and when we cover the left eye, we find that the right eye moves. So the movements on the alternate cover test have not yet been neutralized, and the power of the prism is not adequate, and the power of the prism needs to be increased. And when we position prism of the appropriate power and perform the alternate cover test, when we cover the right eye, we find no movement of the left eye, and when we cover the left eye, we find no movement of the right eye. So prism and alternate cover test gives the measurement of total deviation, that is heterophoria plus heterotropia, and it is based on this measurement that surgical corrections are usually planned. In pediatric or restrictive strabismus, primary deviation is measured with the prism placed over the affected eye so that the normal eye fixates the target, and secondary deviation is measured with the prism over the normal eye so that the affected eye fixates the target, and we have seen in a previous session that secondary deviation is always more than the primary deviation according to Hering's law. We may note here that primary and secondary deviations refer to pediatric and restrictive strabismus and not to strabismus patients with normal ocular movements. And when both hands of the examiner are engaged to hold the occluder and the prism, the patient can be asked to hold the target while measuring deviation at near fixation. Now we'll digress from the main topic and discuss a little about prism, which is very important to understand the main topic. When a light ray passes through a prism, the light ray is deviated towards the base of the prism. So in this diagram we see a target on which the subject fixates, so the light ray from the target passes through the nodal point of the eye and to the fovea. Now when we position a prism in the path of that light ray, the light ray is deviated towards the base of the prism, and to the subject it appears that the target has shifted towards the apex of the prism. And if the other eye is occluded, the subject rotates this eye to take up fixation of this deflected image. Prism strength is measured in prism diopters, and a prism of 1 prism diopter deflects the image of a target at 1 meter distance by 1 centimeter. And as we see by geometry, the relation between the angle of deviation and the prism diopter is not linear but a tangent. And for small deviations up to 45 degrees, 1 degree of angular deviation is equal to 2 prism diopters of prism power. And this relation is very important to remember. In a patient with heterotropia and normal retinal correspondence, the image of the target being fixated by the fixating eye falls on a non-foveal position in the deviated eye, and thus the patient has diplopia. And when a prism of appropriate power is positioned over the eye, that light ray is deviated towards the fovea, and since the patient has normal retinal correspondence, the directional value of both the foveas are the same, and the patient no longer perceives diplopia. So when a prism of appropriate strength is positioned with the apex towards deviation, the patient does not perceive any diplopia, and as a result the eyes do not move on alternate cover testing. Some principles of using prisms are as follows. As we have noted, apex of the prism should be positioned towards deviation, and the orientation of holding the prism is also important to ensure that there is minimal deviation of light passing through the prism. Plastic prisms, which are now routinely available, should be held with their surface towards the patient parallel to the frontal plane of the patient. And glass prisms, which are rarely available nowadays, should be held with their surface towards the patient perpendicular to the visual axis. And we note here that parallel to the frontal plane and perpendicular to the visual axis are not the same. If the patient has a head tilt, the prism needs to be tilted accordingly towards the left or the right. And if the deviation is larger than the strongest prism available, one prism should be positioned over one eye and another prism should be positioned over the other eye so that their strengths can sum up. However, two vertical prisms or two horizontal prisms, that means prisms with bases aligned, should never be placed over the same eye, because then the net prism strength becomes much more than the sum of the strengths of the individual prisms. However, one vertical and one horizontal prism, that is prisms with bases separated by 90 degrees, can be placed over the same eye when we have a combination of vertical and horizontal deviations. Simultaneous prism and cover test measures only heterotropia, so we note here that it is cover test and not alternate cover test. and it is thus the best measurement of deviation under real-life conditions. The fixating eye is covered and prism positioned over the deviating eye simultaneously, and the test is repeated by changing the prism power till there is no movement. So when we perform simultaneous prism and cover test on the same patient with left eye exotropia, we position the cover over the right eye and the prism over the left eye with apex towards deviation, and with the prism of the appropriate power we find no movement of the left eye. Corneal light reflex tests also evaluate ocular alignment, but they are not as accurate as cover tests, but can be performed in uncooperative patients and those with poor vision. These tests are based on the correlation between decentration of the corneal light reflex and the magnitude of the ocular deviation, which has been found to be approximately 15 prism diopters of ocular deviation per millimeter of decentration of the corneal light reflex. The corneal light reflex is actually the first Purkinje reflex from the anterior corneal surface of the fixation light source. However, since the target is a light source, corneal light reflex tests do not allow control of accommodation, and corneal light reflex tests are always done from near and cannot be done from a distance because of faint reflex from a distant light source. Hirschberg test estimates deviation grossly and is helpful in an uncooperative child. The light source is held at 33 centimeters, and to make the patient accommodate, an accommodative transparent target can be pasted on the tip of the light source. The reflex is first centered on the pupil of one eye, and the position of the reflex in the second eye is then assessed, and then the test is repeated with the reflex centered on the second eye, with the position of the reflex in the first eye being assessed. For an average sized pupil of 4 mm diameter with the corneal light reflex centered on the pupil in the first eye, if the light reflex in the second eye is midway between the pupillary center and the pupillary margin, the ocular deviation is considered to be 15 prism diopters. And if the light reflex in the second eye is on the pupillary margin, the ocular deviation is considered to be 30 prism diopters. If the light reflex in the second eye is between the pupillary margin and the limbus, the ocular deviation is considered to be 60 prism diopters. And if the light reflex is at the limbus, the ocular deviation is considered to be 90 prism diopters. However, pupil sizes significantly different from 4 mm in diameter will give wrong estimations of the deviation. Krimsky's test is the other corneal light reflex test which can be done in an uncooperative child. The light source here is also held at 33 cm, and an accommodative transparent target can be pasted on the tip of the light source to make the patient accommodate. The prism is held either before the deviated eye or the normal eye. When the prism is held over the normal eye, it is called the modified Krimsky's test, and the prism power is changed till the corneal light reflexes on each of the eyes is centered. So this diagram shows that with the light reflex on the limbus in the second eye suggesting an ocular deviation of approximately 90 prism diopters, when a 90 prism diopter prism is placed in front of the eye with the apex towards deviation, the corneal light reflex becomes centered in both the eyes. So here we note that in the corneal light reflex tests, we assess the centration of the corneal light reflex and not movement of the eyes, which we assess in the cover tests. Now we'll once more digress from the main topic and discuss about angle kappa. Angle kappa can affect results of corneal light reflex tests. To an external observer or an examiner, it appears that the patient is viewing through the center of his or her pupil, and angle kappa is the angle between the pupillary axis and the visual axis. The pupillary axis, as represented by the blue line here, passes through the center of the pupil and is perpendicular to the cornea. The visual axis connects the fovea with the fixation target. Normally, the fovea is situated temporal to the pupillary axis, and the corneal light reflex, which lies on the visual axis and is located where the visual axis intersects the anterior corneal surface, thus is located nasal to the pupillary center. And this situation is called positive angle kappa, as shown here in the diagram for the left eye. The corneal light reflex is represented by the white dot, which is nasal, to the blue dot representing the center of the pupil, and from where it appears that the patient is viewing. Normal values of angle kappa are 5 degree in emmetropic eyes, slightly higher in hyperopic eyes, and slightly lower in myopic eyes. When the fovea is dragged temporally, the corneal light reflex is shifted further nasally away from the pupillary center. The angle kappa becomes more positive, and as seen here in this diagram, it appears that the patient has exotropia. And when the fovea is situated nasal to the pupillary axis, the corneal light reflex is situated temporal to the pupillary center, and in this situation the angle kappa is said to be negative, and as seen here in this diagram, it appears that the patient has esotropia. Cover tests can distinguish abnormal angle kappa from actual strabismus, because in abnormal angle kappa, eyes do not move on cover tests. This is because strabismus is not present, and so both the fovea are fixating on the target. Subjective tests of ocular alignment reflect the true ocular misalignment only if there is normal retinal correspondence, that is, anomalous retinal correspondence or suppression is absent. Anomalous retinal correspondence or suppression do not develop in adults and children older than 7 to 9 years of age. So subjective tests are applicable to this group of patients. Subjective tests require patient cooperation, intelligence to understand the test, and ability to communicate his or her subjective perception. Subjective tests disrupt fusion and so cannot separate fovea from tropias and only reveal the total deviation. A Maddox rod contains parallel cylinders as shown here in this photograph, and when the patient looks at a point source of white light through this Maddox rod, the patient sees a line, and this line is oriented perpendicular to the cylinders of the Maddox rod, and the color of the line is the same as the cylinders of the Maddox rod. This photograph shows a Maddox rod positioned in front of the eye with its cylinders oriented vertically. So when the patient is shown a point source of white light through this Maddox rod, the patient will perceive a horizontal line perpendicular to the vertical cylinders, and since the cylinders are red in color, the horizontal line will also be red in color. By convention, in the Maddox rod test, the Maddox rod is positioned in front of the right eye, and usually a red colored Maddox rod is used. Accommodation is not controlled because the target is a source of light. Horizontal deviations can be more easily detected when the patient perceives a vertical line. So the Maddox rod is positioned in front of the right eye with the cylinders oriented horizontally so that the patient can see a vertical line with the right eye. When the patient perceives the image of the point source of light in the center of the vertical line, the patient has horizontal orthophoria. In isodeviation, including isophoria and or isotropia of either the right eye or the left eye, the vertical line seen by the right eye lies to the right of the point source of light seen by the left eye, and so it is called an uncrossed diplopia because the right eye image lies to the right of the left eye image. In exodeviation, including exophoria and or exotropia of either the right eye or the left eye, the vertical line seen by the right eye lies to the left of the point source of light seen by the left eye, and so it is called a cross diplopia because the image seen by the right eye lies to the left of the image seen by the left eye. And we have a mnemonic here with x of exo corresponding to x of crossed. Similarly, vertical deviations can be more easily detected when the patient perceives a horizontal line. For that, the Maddox rod is positioned in front of the right eye with the cylinders of the Maddox rod oriented vertically so that the patient sees a horizontal line with the right eye. When the patient perceives the point source of white light at the center of the horizontal line, the patient has vertical orthophoria. In hyperdeviation of the right eye, which can be a hyperphoria or a hypertropia, the horizontal line is seen below the point source of light. And in hypodeviation of the right eye, which can be a hypophoria or a hypotropia, The horizontal line is seen above the point source of light. So we note here that in vertical deviations there is a crossing over of the image, with the higher eye seeing the lower image and the lower eye seeing the higher image. The double Maddox rod test is used to detect and measure cyclotorsion. In this test, two Maddox rods of the same color are placed one in front of each eye on a trial frame, and the orientation of the two Maddox rods are the same, usually with their cylinders oriented vertically, so that the patient sees a horizontal line with both the eyes. Subjects without torsion see two horizontal lines superimposed on each other. For better detection, a vertical prism can be placed in front of one eye, and to a normal subject, the separated horizontal lines appear parallel to each other. But in patients with cyclotorsion, the two lines appear at an angle to each other. The patient is then asked to rotate one Maddox rod to superimpose or make parallel the two lines, and the amount of rotation shown on the trial frame gives the angle of torsion. Haploscopic tests present significantly different targets or images to the two eyes, and we will be discussing three haploscopic tests: Diplopia charting, Hess screen, and Amblyoscope. In Diplopia charting, patient wears a red-green glass and keeps his or her head steady. The examiner projects a linear white light towards the patient in 9 diagnostic positions of gaze. The examiner projects the light vertically in case of horizontal deviation and horizontally in case of vertical deviation. Here we see a patient with a horizontal deviation, and so the examiner projects the linear light vertically. In each of the 9 diagnostic positions of gaze, the patient describes whether the red and the green images are fused or separated, and if separated, whether each image is vertical or horizontal as shown, or is tilted, and if tilted, orientation of the tilt, the separation of the images, and the color of each image. The test is repeated with glasses reversed. That means if the test is first performed with the red glass over the right eye, then the test is again performed with the red glass over the left eye. In a patient without strabismus, the images are fused with each other in each of the 9 diagnostic positions of gaze. If the images are separated, the separation between the two images is maximum in the direction of action of the parietic muscle. And in this gaze position, color of the furthest image from the primary position identifies the paralyzed eye as the one wearing the same color glass. So a patient with a right lateral rectus palsy will have image separation more on the right side, in the direction of action of the lateral rectus of the right eye, and the color of the image farthest from the primary position will correspond to the color of the glass in front of the paralyzed eye. In diplopia charting, direction of maximum separation is opposite to the direction of deviation of the paralyzed eye. So in right lateral rectus palsy, the right eye will be deviated towards the left side and the maximum separation will be towards the right side. So the maximum deviation to the right can be caused by either right eye esotropia, as we have discussed, or by left eye exotropia, in which case the left eye would be deviated towards the left side. In diplopia charting, esotropia produces uncrossed diplopia, exotropia produces crossed diplopia, hypertropic eye sees the inferior image and hypotropic eye sees the superior image, which matches with the perception through a Maddox rod. Hess chart is a haploscopic test which allows measuring of the horizontal and vertical deviations but not torsional deviations, because it uses a point source of light and not a linear source of light, and it can also monitor improvement or deterioration of deviation with passage of time. Presently, electronic Hess screens are used and the screen is positioned 50 cm from the patient. At this distance, the chart points are 5 degrees or 10 prism diopters apart. The screen has a red light source at the center, and inner area extending 15 degrees from the center with 8 red lights at its outer margin, and an outer area extending 30 degrees from the center with red light sources at 16 points. So this is the Hess screen and these are the Hess charts which the examiner uses to record his observation. So the patient wears a red-green glass and keeps his or her head steady at a distance of 50 cm from the Hess screen. The eye with the green glass is the eye being tested, and so the appropriate recording chart should be used. In this diagram, the right eye is being tested, so the examiner must use the right eye Hess chart for recording his observations of the patient's response on the Hess screen. Then examiner switches on each of the red lights one at a time. So when this red light is turned on, this red light is seen only by the eye having the red glass and is not seen by the eye having the green glass. And the patient has a handheld green light projector which projects a green light. And this green light is seen by the eye with the green glass but is not seen by the eye with the red glass. So with each red light turned on, the patient projects a green light towards the red light to subjectively superimpose them. So the patient perceives that the two lights are superimposed. When the subject sees the two lights superimposed on each other, the examiner will observe the two lights superimposed if the subject has no strabismus. But the examiner will observe the two lights as separated if the subject has strabismus. This is because when the eye with the red glass fixates on the red light lit up on the screen, the red light projects onto the fovea. Then when the patient attempts to superimpose the green light over the red light, the patient will position the green light in such a way that the green light projects onto the fovea of the eye with the green glass. This is because in normal retinal correspondence, the directional value of the fovea of the eye with the green glass is the same as the directional value of the fovea of the eye with the red glass. And so only then the patient will perceive that the two lights are superimposed. So in a patient with misaligned visual axis, when the patient attempts to superimpose the two lights, the observer sees that the two lights are separated, and the examiner plots the locations of the green light for each of the red lights on the recording chart for the eye with the green glass. The locations of the green lights recorded for each of the red lights of the inner area are then sequentially joined by straight lines, and so for the green lights plotted for each of the red lights of the outer area. The test is then repeated with the glasses reversed, and then the other chart is used to record the findings. Displacement of the green light corresponding to the central red light measures the deviation in the primary position. In the chart for the paralyzed or the restricted eye, the area will be reduced on the side of action of the paratic muscle or opposite to the side of action of the restricted muscle, indicating underaction of the paratic muscle or limitation caused by the restricted muscle. So in a right lateral rectus palsy, since the lateral rectus of the right eye moves the right eye on the right side, the area of the Hess chart will be reduced on the right side. And in the chart for the contralateral eye, the area will be increased on the side of action of the paratic muscle or opposite to the side of action of the restricted muscle, indicating overaction of the yoke muscle in the contralateral eye. So in a right lateral rectus palsy, the yoke muscle to the lateral rectus of the right eye is the medial rectus muscle of the left eye, which moves the left eye towards the right side. According to Hering's law, when there is a palsy in a muscle in one eye, there will be overaction of its yoke muscle in the other eye. This overaction also occurs when there is a limitation in the movement of the first eye in the same direction but due to a restriction. And this overaction will be reflected in the increase in area of the Hess chart of the normal eye in the same direction as the reduction in the area of the Hess chart in the eye with the paralyzed muscle. Principle and interpretation of Lancaster red-green test and Lee's green test are similar to Hess green test. All three tests, Hess, Lancaster and Lee's, can detect and measure horizontal and vertical deviations. But since Lancaster test uses a slit instead of points of light, it can also detect torsional deviation. An amblyoscope or synaptophore can be used for various purposes in strabismology. To measure ocular alignment, the patient is shown two dissimilar images through the two tubes of the amblyoscope and is asked to superimpose them. Then the angulation between the tubes gives the angle of deviation between the two eyes if there is normal retinal correspondence, and horizontal, vertical and torsional deviations can be measured. So when a patient with normally aligned eyes perceives a single superimposed image, the angle between the two tubes is 0. But a strabismus patient with misaligned visual axis cannot superimpose the two dissimilar images when the tubes are parallel to each other. And when the strabismic patient is asked to superimpose the two images by rotating one of the tubes, the two images will be superimposed when the angle between the two tubes is equal to the angle of deviation between the two eyes. To recap the salient points, inquiring about nature of diplopia is very helpful as regards whether the diplopia is monocular or binocular, whether the separation of images is horizontal, oblique or vertical, and about the variability of separation of images with distance of fixation, gaze position and time. Tests which disrupt fusion cannot differentiate between heterophoria and heterotropia. Tests which measure deviation must control accommodation with an accommodative target. Deviation should be measured at distance in all 9 diagnostic positions of gaze and right and left head tilt, and at near in the primary position. Cover tests require foveal fixation, eye movements, and ability to fixate on an accommodative target. Cover test detects heterotropia, uncover test detects heterophoria, alternate cover test detects heterotropia plus heterophoria, alternate cover test with prism measures heterotropia plus heterophoria, and simultaneous prism and cover test measures heterotropia. Prism should be positioned with its side facing the patient in the patient's frontal plane and with the apex of the prism towards the deviation. Corneal light reflex tests without and with prism is performed by focusing light from near and observing the relation of the corneal light reflex with the pupil and the limbus. Results of corneal light reflex test can be confounded by an abnormal angle kappa. In a patient without strabismus but with an abnormal angle kappa, there is no movement of the eye on cover tests. Subjective tests of diplopia include Maddox rod, double Maddox rod, diplopia charting, Hess screen, and Amblyoscope. Among these tests, double Maddox rod, Amblyoscope, and diplopia charting can detect torsion, with the first two tests, double Maddox rod and Amblyoscope, being able to measure torsion also. Thank you for listening.